for that. Let me also share a story, if I will, and I'll be brief, about why I think the Affordable Care Act and health reform in this country, and what we've been doing for decades in Maryland, matters. My father's a doctor, and while Donna shared with you the truth that not all lawyers are wealthy, the same can be said about doctors. My father grew up in a very poor neighborhood in Kingston, Jamaica, Trenchtown, and he was raised by his grandmother in a very loving, caring home. A home that was surrounded by a community that was plagued with poverty, tremendous amount of hardship, illness and disease. Much of it never went in November. My grandmother was in this country as an illegal immigrant. And she sent for her son. He was the first in our family to get a college education, and he went on to medical school and spent his entire career seeing patients in some of the poorest neighborhoods and the poorest hospitals near where I grew up. And because of that college education that he got in this country, he was able to make a tremendous difference in the lives of so many of our neighbors. So that's kind of a little pitch for the Maryland Dream Act. When I went off to college, and I returned for my first Thanksgiving break, I went down in my parents' basement, and my father's 88 and my mother's 85. They still live in the same home that I grew up in. And my father had these file cabinets in the medical office that he had when I was a young boy, rows and rows and rows of them, long before the iPad and health information technology, rows and rows and rows. And when he closed that practice in the late 60s, early 70s, he moved one of those filing cabinets to the basement of our home. So about 10 years later, or a little bit longer, when I returned from college for that first Thanksgiving break, I went down in the basement and I saw that file cabinet, and I opened it up. Where are the lawyers? HIPAA was not in effect at the time. I opened that cabinet up, and I'm thumbing through it, and I began to recognize the names of some of the people on the correspondence, the papers there, and I recognized the names because when my father was raising his family, he would come home and he would share stories about his patients. And again, this is long before HIPAA. And he would come home and he would tell us about Mrs. Smith, who was responding well to treatment so she could return to work and provide for her family. He would come and tell us about little Johnny, who just got his cast off and was able to go back on the baseball diamond and live a full, complete life as a little boy, growing up, going to school, so that little boy, Johnny, could one day be whatever he wanted to be in his life. My father loved his patients. And what my father didn't make in a paycheck was more than compensated for by the satisfaction he found in knowing that he made a difference in the lives of his patients. As I was going through this correspondence, these documents, I noticed that most of them were invoices. And I also noticed, as I looked a little bit deeper, that the lion's share of them were unpaid invoices. And it was at that time that I realized a lesson that my father tried to teach his children when we lived under his roof. And for me, I only really realized it that day when I thumbed through that file cabinet, that you have to serve other people before you get around to serving yourself. And that's what my father did each and every day. He tried to make a difference in the lives of the people that he touched, whether they were able to afford his services or not. And that's why when I think about the Affordable Care Act and all the tools that it's going to give us in the state of Maryland, the tools that it will give providers, the tools that it will give advocates, but most importantly, the tools or the benefits that will provide for patients. That's why I'm so excited about the Affordable Care Act and expanding health coverage to so many more Americans for whom today it's out of reach. In Maryland, we anticipate that we're going to expand access to coverage to about 450,000 Marylanders. About 235,000 of those Marylanders will be women, and then their families. Some of them through a Medicaid expansion, others through affordable commercial products. But that's why I'm really excited about the Affordable Care Act and how we're going to expand coverage. But let me just say this, and I too will not get overly partisan, but I came back from Charlotte. I was in Charlotte, and we teed up the choice that Americans will make come November. And there's really two completely different candidates with sort of a perspective and a view of the world. Both love this country tremendously. Both have wonderful families, but a different perspective and a different view. And if your view is that in the area of healthcare, each of us as individuals, and no less women, should be able to make the decisions that affect their own health and the health of their family, there's one candidate that believes strongly in that, and there's another that just has a different view. If you believe that we as a society and a community, when we're making those decisions about health care and other issues that affect individuals, particularly women, and you believe that all of us, particularly women, should be involved in those public collective decisions, there is a difference in the two candidates. One of them believes strongly in inclusion and diversity, and that those who are impacted by decisions ought to be participants in the decision-making process. So you go check the record, and you make the decision. I came back from Charlotte very excited, and I've already made my decision. But I won't get partisan on it. So I believe that the greatest challenge that we face in this day and age as leaders and as individuals is to address the persistent gaps and the debilitating disparities that exist in our communities. The achievement gap in education and college completion, the health disparities that exist in our communities. Maryland's a great state. We've got some of the finest health facilities, Johns Hopkins, University of Maryland Medical System, 43 community hospitals around the state doing tremendous work. We've got smart people in Maryland, both in delivering health care and setting policy for health care, but we still have health disparities. And it's troubling to me that we are one of the wealthiest states in the country, yet we rank 43rd when it comes to infant mortality. And that a little black boy is 2.5 times more likely to die before his first birthday than a white boy. That is unacceptable in the state of Maryland. And it's unacceptable to me that we are 35th when it comes to infectious disease, 33rd in health outcomes. And that an African-American woman in this country, in Maryland, is less likely to be diagnosed with breast cancer than a white woman, but more likely to die of breast cancer than a white woman if she is diagnosed. That's unacceptable. Not in a great state like Maryland, and not in a great nation like America. And the health disparities that I'm concerned with aren't just around racial, ethnic, and gender. It's also around geography. We rank 33rd. That's number one is the best. We rank 33rd among 50 states when it comes to geographic health disparities. We rank 1 or 2, 1 being the best, in the number of primary care providers per capita. So since my father is a doctor, I can say this tongue-in-cheek. I don't know where all the doctors are in the state of Maryland. I suspect a lot of them live close to the nation's capital or lobbying Capitol Hill on some issues involving healthcare. Maybe that's where they are. They're not in Prince George's County. 33rd. So, in a healthcare system that we are reforming for the benefit of all, there are some things that we can do to address health disparities. I mentioned the Affordable Care Act and the Health Benefits Exchange, expanding health coverage to 245 women, and out of that 750,000, while I don't have the data here, I can assure you that a disproportionate amount, in a good way, will be African Americans and Marylanders of color. And Donna mentioned the preventive services for women that will be provided without co-pays and deductibles. What else do we do to address health disparities? We're going to build upon local health action coalitions to address 39 measurable health outcomes, and 28 of which are directly linked to health disparities. But the other thing that we're doing that I'm very excited about, how many of you have heard about the Health Enterprise Zone? Okay, that's not bad, about half. And the Health Enterprise Zone, which we created this program during the legislative session, we are going to provide, there's no other state in the country that's doing this. And in a time when budgets are tight and most programs are flat funded and many are reduced in spending, the governor and I put $4 million in our budget this year to create these health enterprise zones where we are going to target communities in Maryland that have high health disparities. And we are going to provide income tax credits, hiring credits, loan repayment, grants to providers and other community resources that are willing to bring additional resources into those communities, primary care and community resources, so that we can make a difference in addressing health disparities. Because for far too long we've been talking about addressing health disparities. We've been doing some good things, but we really haven't moved the needle a whole lot. One of the things I found in the health delivery system, even where you have the most well-intended, the best, the well-intended individuals, is it's a big system. And in order to get it to move in a way that where you achieve the outcomes you want, you got to incentivize behavior. Think about health information technology. Everybody says, oh, that's a great idea. Health information technology, get the provider the best information about the patient at the right time for the right diagnosis. But then when those providers walk away from that conversation that we're having about health information technology, they don't implement it. Why? Mostly because it costs money. Right. Think about hospital readmissions. The idea that someone's going back to the hospital within 30 days for something related to their initial admission, not only is it disrupted in their lives, it costs money, it costs time, and sometimes it costs lives. You could sit down with a bunch of hospital administrators, all well-intended, say, should we reduce readmissions? Absolutely. They'll walk away from the table, they won't do a whole lot about it. Why? Because it's money. It costs money. So, we create incentives or penalties to reduce readmissions. If we have health disparities in Maryland, how are you going to get this big system to move in a way where we make a difference and we change behavior by providers to reduce health disparities? That's why we created the Health Enterprise Zone. $4 million to provide real incentives to get providers to change behavior. All of them are well-intended, to change behavior, to make a difference. And we're going to measure our results. So we're really excited about that program. Let me finish with this. What can you do to help make a difference? Being here today is what you can do. Educating yourselves. I know so many of you are advocates. I see so many familiar faces out here. You've been fighting on the policy level in the community, making a real difference. What can you do? Join the Maryland Women's Coalition for Healthcare Reform. That's one thing that you can do. Get involved in your community through your local health department, through the SHIP's Local Health Action Coalition, or other groups committed to ensuring that health reform as implemented in Maryland is as successful as it can be on behalf of our neighbors. Thank you very much for being here today. I wish you the very best.